Good morning, everyone. Thank you so much for being here. As our announcement said, my name is Evan Rosenberg. I'm the publisher of the Pittsburgh Business Times. Honored to be with all of you and our esteemed panelists. We are gathered here on the campus of the University of Pittsburgh, where medicine, science, and technology converge, where AI and human insight are redefining health itself. And Pittsburgh is uniquely suited for this. Pitt's leadership in medicine, Carnegie Mellon's strength, obviously, in AI, and partners like UPMC and Highmark are turning innovation into care. Today's focus, we want to be a practical conversation. What's working now, what's coming next, and how to ensure the tech enhances, not replaces, the human side of care. So with that, let's get started. Human, I'd like to actually start with you. Where is AI already making a measurable impact, whether it's in diagnostics, education, or patient care? Maybe start there to frame the conversation.
Sure, thank you. Thanks so much, and thanks for joining us. So I think it's important for us to realize that, because I get this question asked, plenty of times. And I think the biggest misconception we have out there that this is all, 100% new to us. And part of it is true. It's the new generative AI that's enamored the world is relatively new. But we've been doing the AI space, and we've been incorporating AI tools in our diagnostics, therapeutics, for decades now. But it's been more on the predictive analytics sides of things. So like AI tools that, for example, my colleague Liron Pantanowicz, he had set up, years before I had come to Pittsburgh, that could identify tuberculosis versus not, or, prostate cancer versus not. So the whole predictive analytics classification tasks, they've been in place, and they are part of our routine care for a while now. The part that we need to collectively realize is that now we have these new generative AI tools that are doing many other things, especially with the new multi-agentic frameworks, that are, yes, in some ways replacing a lot of things that could be automated or routine tasks. And that, obviously brings up a lot of great opportunities, but lots of challenges in there. Personally, I think at the end of the day, it comes down to, yes, we definitely have to incorporate them. There's no way around that. That's part of our world. But we also need to do it responsibly. And most importantly, the part that I'm most passionate about is we have to integrate education into the framework. And this is just from my past experiences at University of California and Cleveland Clinic and others, is that if we don't incorporate education into a deployment framework, the chances of succeeding is, drastically decreased. And what I mean by education is not educating, folks like us in computer science world that are coders. I'm talking about the masses, kind of similar to what happened with the internet era.
Yep.
When the internet basically needed to upskill and reskill people. We're going to have the same needs now with the new AI era, with the need for upskilling and reskilling. So having no-code frameworks that basically is tailored to the masses is not just a nice thing to have, but it's a requirement, quite frank. So I hope that gives you a better sense. And we're leading the way in that in Pitt and CMU on that.
Yeah, but the education piece is a real necessity when you say not for those of you on stage, but for everybody, right?
Yeah, it's for everyone. And I'll give you a great example. The reason why it's so important that everybody needs to know it, especially, obviously, I'm a blood cancer specialist, so from a, let's say, physician side, if you go into the typical workflow in medicine has changed dramatically. If you looked at it 50, 60 years ago, it was typically, if somebody had cancer, it was typically an oncologist and maybe a pathologist who would basically collaborate and come up with a final diagnosis and what's the next care. That has changed completely. That's now a multidisciplinary approach to care. Usually in a tumor board, you have pathologists, radiologists, oncologists, surgeons, social workers, nutritionists, and so pharmacists. So lots of people who are basically part of the patient's care and making sure that they ensure the patient succeeds in their, in their treatment journey, if you will. The part that's missing, even though we've had AI incorporated in various aspects of our triage and system, the part that's missing in every single tumor board, I would argue, is there is no AI-enabled or AI-educated clinical person in these tumor boards. So you're taking the word of the AI tool's prediction at face value, and quite frank, that's a little dangerous.
Yeah.
And so finding ways to have and force multiply those AI champions within these multidisciplinary conferences, that becomes part of a patient safety issue as well.
Yeah, thank you. Dr. Farah, I'd like to go to you. You work for Highmark Health. How is using AI and data to improve patient outcomes, reduce costs, or support clinicians in real time? How is that happening? Talk a little bit about that from your perspective and Highmark Health's perspective, if you would.
Yes, thank you. At Highmark Health, we call our strategy the Living Health Strategy, but at the essence of it is what's been published for over 20 years, which is that 30% of every dollar any of us spend on our healthcare insurance coverage is considered total waste. There's some debate around that. I say it's probably more than 30%. But the patient-physician interaction is great, and we know that patients trust their physicians more than anyone else when it comes to their healthcare. The problem is there's waste throughout the system, and there's a whole, there's dozens of articles that have been published on that. One of the keys to unlock this waste and really reduce it and to improve health outcomes is to integrate the payers and providers. We believe strongly that unless you have that deep level of integration between payers and providers, I'm talking about any payers and providers now. In our case, we are an integrated payer-provider system. That should be a key to unlocking that. And so what this means is that we have, we cover 7 million lives across 4 states. So this data, that's claims data that we have at our disposal, is key to blending it with clinical data so that you get the power of the data, the technology, the integration between claims and clinical, and then putting the workforce from both entities to work together to improve outcomes. And I'll give you a couple examples. So for instance, we know that if I see a patient in the clinic or in the hospital, that's great, but then healthcare happens progressively outside of my clinic or in the hospital. That's where things fall apart. And so we've been able to create a growing number of scalable clinical programs, scalable through digital, telehealth, and otherwise, to reach that number of populations. And back to the multidisciplinary comment, we have a number of folks, both clinicians and non-clinicians, who outreach to those populations to improve their outcomes. And when we do that, by the way, we've been able to figure out through the data that the total cost of care comes down, and we know that healthcare cost and affordability has been a huge problem. That's just one aspect of it. The second aspect, I would say, one of the biggest problems we're facing right now, both from physicians and patients, is the lack of time on the provider side. And so doctors across the country spend a lot of time with the patient on their keyboards because they have to do this administrative work, and what we call pajama time at night, a couple hours on average, that's been documented, just catching up on notes and so forth. So us, among others across the country, and we've recently partnered with a bridge, which is based here in Pittsburgh. We have a long-term partnership with a bridge. All of our doctors right now, primary care and specialists, are using ambient listening that enables them to look at the patient while they're talking to them as opposed to typing on the keyboard. And that we've already documented a pretty significant improvement in patient experience, physician experience, as well as a reduction in this, what we call pajama time. We've also been doing a prior auth at the same time so that that's been a big problem for both patients and providers and insurance companies. And we've created this unique gold carding program that bypasses the entire thing using AI so that you can have real-time approval of whatever the physician wants to order before that patient leaves the office.
So using AI to allow physicians to be physicians more so and less so administrators.
That's right.
Fair? Yeah. Brent, Dr. Farah spoke about integrating AI within a large health system. From your seat at UPMC Enterprises, you're focused on building and investing in some of those innovations. What makes an idea scalable and or commercially viable in the real world of healthcare, would you say?
Yeah, no, thank you. And again, thank you for having me. You know, within our group within UPMC, we're looking at taking some of the excellent research and technical advances and how do we, you know, share it with the rest of the country, rest of the world. When it comes to AI, we simply kind of look at it in, you know, three lenses. You know, patient experience, some of the administrative costs of focus, and a clinical decision support. And kind of building on, I think, a comment around some of the waste within the system, focusing on that middle column of administrative costs. We will look at, you know, certainly the technology and can it produce a return on investment, and you know, how can this be woven into the workflow, whether it be within the care management on the plan side or within the workflow on the provider side in order to scale. So those you know, we look to kind of tick those boxes as we work through this, and then you know, taking it up a couple of levels. It's, you know, is there a market for this? Are we just solving just for ourselves? Are we looking for the broader market? Do we have a team that can evolve their product and their technology over time and adapt to a really quick changing world? So I'll pause there.
Yeah, but it's interesting what you just said too. Are you solving for a problem that you have, mm-hmm. or are you solving for a broader problem? I presume the answer sometimes is one or the other.
Yeah. Is it a broader problem? I think is what I think the other piece, and we were talking about this briefly in the green room, is when we talk about some of the predictions, they are outstanding, but we are constantly asking ourselves, well, so what? How are we going to arm the clinician to do something about it? And that's sometimes where we get stuck.
Yeah, sure. Makes sense. So let's go into sort of we're calling it the AI engine room. Pradeep and Carl, this is for both of you. From Carnegie Mellon's vantage point, what advances in machine learning or data science are most likely to change healthcare practice in the near term? And either one of you take that.
So I guess a couple of things I would say. So you brought up Gen AI that has done really amazing things like ambient AI, audio, text, images. Gen AI does wonderfully. But the interesting thing is that a lot of healthcare data is structured and numeric. It's numbers. It's longitudinal. And we really want to work with that to understand patients over time using all of their numeric data. And Gen AI actually doesn't work that well for data like that. And so that's actually a frontier that AI research is working on to extend Gen AI to numbers, numeric intelligence. So that's one area I would say I think would really help a lot, especially for health intelligence. Another would be, and so this, again, you brought up the question of education of folks in healthcare in terms of the AI capabilities, but it's actually worth thinking about whether AI field as a whole has a role to play there as well, in the sense that it's not just that, okay, they're going to develop AI, and then it's the role of everybody else to understand what that is and make it work for their use case. It's worth asking, can the two meet so that you develop AI more specifically for doctors, for healthcare practitioners, and what would that look like? And one aspect of that, specifically in terms of the frontier research, is can healthcare practitioners incorporate context that they have? Because right now what happens is there's this question of translation where the healthcare providers, the doctors, they talk about, okay, this is what they need, and folks in AI then go back and then they develop something else. And I've heard this from multiple people that it's two people talking past each other, you're developing solutions. Right. And again, there is a lot of innovations happening in terms of, okay, you have an AI system, but can doctors incorporate their context directly using high-level, they don't need to know AI, but can they incorporate their context so that they can steer the models to their purposes? So this is, again, something that's happening.
Yeah, Carl?
Yeah, I agree with everything that Pradeep just said. And I think there's another place, both at the clinical level, but also preclinical and in the sort of basic biological sciences, drug development, and things like that, where AI is playing a role right now, and there's a lot of research to expand its role. For example, there's a lot of research using generative AI to do molecular design, mRNA optimization, design of new vaccines, design of small molecules, design of new proteins. And that, that when you talk about drug development soon, impact soon is a relative term. It's a long road, but those kind of technologies are being used and advanced right now, as well as, better biomarkers, which have all the promise and issues that you mentioned about trusting them, but with new AI systems, integrating multiple data types to make better predictions about individual patients. And then two other places that are, I think, really exciting are the integration of AI systems with experimentation. So actually developing drugs in a system that includes experimental validation, data collection that is directed by the AI. So you have a loop that can generate new therapeutics, new biomarkers, and things like that much more efficiently. And then lastly, I think there's a role for AI to play, not just for clinician scientists. So some of them, when you talk about making an impact with a biomarker or drug discovery or new drug, you really need to be talking with, obviously, the physicians who have spent decades learning the expert ins and outs of that particular disease. And you have, we at CMU, we have a PhD program in computational biology. It's 20 years old this year. It trains people in AI from the very beginning and biological knowledge, but there aren't that many people at that intersection. And so a way for AI to enable, with natural language interfaces, clinician scientists to do deep data analysis to understand their patients and their data better really is an early engine that could be developed to advance new therapies, new treatment selection, and new drugs.
Yeah, that's interesting, and I want to come back a little bit to that too, because I think proximity to where we are, right? Carnegie Mellon doing what it does, and the University of Pittsburgh doing what it does is also a really interesting place. I mean, it's amongst the reasons we're all here today. So I want to come back to that. Andrew, let's talk about some basics. Maybe help our guests from your perspective understand a little bit more about AI.
So I'm a basic scientist. I study processing in cerebral cortex, and I look at the nitty-gritty of how neurons speak to each other and how they communicate. And there's a big correspondence between the large-scale networks. All these artificial intelligence systems are based on artificial neural networks. And they've evolved to a point now where they're becoming close to the complexity of biological systems. And so we're faced with a problem. We don't understand how brains or the cortex works. We don't understand how these large-scale neural networks work. In fact, there's sort of an inside joke. How did the large language model cross the street? And the answer is, we don't know, but it sure does it well.
There you go. There's one for all of you to take away.
So I think, everybody needs to understand that. The development has happened in, making powerful computers that can handle huge databases and compute fast enough so that you can do brute force back propagation through these networks that train them. But there has been very little work in trying to understand how these things actually work. And I think we all need to, or everybody, right, that's going to be using these needs to keep that in the back of their mind. And that's sort of my view on this.
Yeah, thanks, Andrew. Robert, you are a surgeon. You are a brain surgeon. How is AI supporting decision-making or precision for you and your colleagues in the OR?
Well, thank you for the question. I appreciate the opportunity to be here. So being a clinician scientist myself and having the privilege of leading the largest department of neurosurgery in the nation gives me the opportunity to really push our faculty and our agenda forward. Obviously, being part of the University of Pittsburgh and the School of Medicine and UPMC, being so close to Carnegie Mellon, just puts us in a biosystem that we can go and really develop all these. And I'll give you a few examples. Gamma knife, as an example, is a technology that was brought into North America by a former department chair, Dave Lunsford, and that was a huge progress that was made years and years ago. But you have the neurosurgeon and the radiation oncologist looking at a screen and saying, this is tumor, that's not tumor, and this is the dose that we're going to give it, and it's a human doing a great job at it, but it can be done better. Our colleague Kostas Hatsapanayas, who's the new director of the Gamma Knife Center with the team, are developing an AI-driven model where it's the way it should be, where you go and you see an image, and with assistance of AI tools, you understand exactly what to treat, what dose to treat. So that's one example. Another example is Marco Capogrosso, who's a neuroscientist who's using the best of technology and amazing science at making paraplegics and quadriplegics walk with using spinal cord stimulation, or stopping spinal muscular atrophy using technology for this. Ted Andrews, another neurosurgeon, using augmented reality driven by AI to make our surgeries better and safer, as for the surgeon to go in with goggles and really to see the depths of what you're doing. David Okonkwo developing a blood test for trauma patients in the field that the military are using. And what I want to say about David is also the impact of our department. He's embedded within UPMC enterprises and really bringing his knowledge of our department into there. And lastly, work in my laboratory as an example that we develop new drugs for treatments of Huntington's disease using technology, using focused ultrasound as a technology that opens up what's called the blood-brain barrier to get the drugs into the brain. And finally, the last one, Jorge Gonzalez-Martinez, who's our head of epilepsy and movement disorders, collaborating with several international groups, has developed an AI-driven model to understand brain connectivity, to understand how the brain functions, then using tools to modulate the brain, using deep brain stimulation, but really pushing all of this forward. And I'm thrilled to be able to do this here at a university on our side. Is that there's an ecosystem of people that just push themselves all the time.
Robert, let's stick with you, and I think this is, sort of has come up, but it's certainly relevant to everybody here. Talk about sort of the ethics of it. How do you ensure that AI is really used to support, but not substitute, clinical judgment, right? You're a highly trained professional. How do we ensure that training is what is being used and not just trusting what's coming at us?
So I'll quote my son, who's a computer scientist and working in AI, and he tells me artificial intelligence is not intelligent, it's dumb. It's brute force of putting a lot of computer information together and you put in some data, and you get a result. But you still, particularly at this stage, you need a human just to make sure that it's correct, particularly when we're talking about medicine and the function of the brain, which is what I work. And there's so many nuances from a patient's point of view that you really need to marry both. Again, human intelligence by itself is good. Artificial intelligence by itself is very good. But really is the marriage of putting them both together in expert hands so you can really understand what the information is and how to use it.
Houman, let me go to you. How do you talked about education, and again, you talked about education for everybody, but the masses in particular. But how do you prepare future clinicians to work with AI responsibly?
Yeah, no, that's, quite frank, I don't think any of us have a perfect answer around this.
Right.
We're learning as we go, right?
Yep.
But I think kind of, go after the low-hanging fruits is probably the best thing to do right away. Finding out exactly where the, missing areas are, as Deep said, there is this known paucity of, or a lack of a bridge between those of us in the development world and the clinical groups, and finding ways where people can understand each other's languages. They don't have to become, the physician scientist or the end user doesn't have to become a computer scientist, and vice versa. The computer scientist doesn't need to become a physician. But if they understand each other's language in terms of the basics, and that would be very important. The other reason I pitch that it's so essential for the society as a whole, for the clinical folks to have AI champions, is that let's just face it, at Pitt and CMU, where this is some of the biggest places on the planet, and in academic institutions, right? But most of the care outside is done outside of academic institutions. So your typical physician that we train ends up actually leaving academia. Many of them are in private practice groups. But pretty soon, they already are actually asked to do, is they're asked to evaluate systems, AI systems, evaluate literature. And so without the background, without the right, educational background, they just have their appealed, or, they can basically appreciate the hype, but they won't really understand the limitations of these systems. So I think the more you have folks who understand the limitations, just because, like it was mentioned nicely, these are just tools. They, human in the loop is most of the time it's the right approach to go about. But at the end of the day, you need that bridge between the developers and the clinical folks to be able to ensure that this is actually deployed in the most responsible, ethical way. The other thing that I would also pitch is kind of related to this, is that we need to also realize that this is kind of related, but also not exactly. I just wanted to throw it in there, is we have different hospital systems out there.
Yep.
And we don't have the same strategy plan for, so the same strategy doesn't work that's working at UPMC Pitt / CMU will not work in many of the private hospital systems. So in making it simple, I think people should also realize that the vast majority of the health system, especially in the private setups, they are, and I would say AHN is an outlier. They're probably in our world more. But many of the smaller hospital systems, their strategy should be finding the right, vendor partner that basically addresses their needs. But obviously, they're going to be, there's going to be hurdles that they're going to be seeing. They won't be able to maximize their, true need on AI like a lot of the academic institutions can. In the academic institution,
because they won't have access to the world of academia in the same way.
That's right. Yeah, having that. So the tools that we should have access to, I think, in our world, in the academic especially world, the UPMC Pitt world or HN world, reality is a hybrid version. Because we all know the playbook. I mean, as somebody who owns some startups, I know how that works. So the playbook is, as you know, the client gets hooked onto the product, and over time, the price of the API and the cost of the software will go up. And so the question is, at what point becomes cost prohibitive?
Yeah.
And so finding ways where you can have a hybrid setup where you build your own custom setups, like we have our own Pitch GPT Plus that kind of addresses a lot of our own needs. That's coming out soon. Or various other AutoML tools that addresses our own needs internally. But not everybody has that. So I think each system has to kind of evaluate their own ROI and seeing how do they maximize that the best way. And more importantly, how do you become fiscally healthy, not just for year 1 to 3, but year 5 to 10.
Yeah, yeah.
And so I think all of these are kind of like, mixed in together around education, deployment, strategy plan of infrastructure. We're in the embryonic stage of this whole thing right now.
And I want to come back to something you said about sort of the combination of academia and medicine, and I'm going to come back to that. But while we're here, Tony, following up on Human, what do you see as the biggest obstacles are to broader adoption? I mean, is it technology? Is it cost? Is it culture? Is it all of the above?
The easy answer is all of the above.
Sure.
But the question is, okay, where do you even begin? What we're solving now versus what we're solving for in the future is all going to accelerate with the help of generative AI. So what we're solving for now, if you think about access to care, I get calls literally 24/7, even after midnight, about lack of access. So can I get an appointment? It takes several months. And this is not just in Pittsburgh, by the way, it's across the country. And so one way we're solving access is the data that I mentioned earlier. We have 7 million members, lots of millions more of data points. What's working behind the scenes is extracting that data and being able to isolate precisely which patients, members, I call everyone patients, do our clinicians or our systems need to reach out to so that we're more precise in how we're taking care of them so we can improve those health outcomes. So I'll give you a couple of examples. If our clinicians are sitting, with patients and so forth, they don't need to figure out how to get all these other clinical programs that I talked about, some of which are digital, some are telehealth, et cetera, to work on their behalf after the patient leaves their clinic. The systems and the AI behind it are constantly learning, and the data is predicting, and it shows up in the patient's, in the physician's workflow. And all they have to do is, because I know what the patient needs, I just click a button that says, okay, this patient with congestive heart failure or a variety of other conditions, diabetes, et cetera, and by that one click of a button, without me having to search or look for anything else, activates a whole bunch of systems, people, technology, so that after the patient leaves the clinic, that patient's taken care of. That's how we're improving health outcomes. Another application, which is not unique to us, but we're doing a lot of it now, is there's a huge physician shortage. It's predicted that by 2034 or 35, we're going to be short 36,000 physicians in the U.S. We've known about this for a long time. It's only going to continue to get worse. And so this is where AI really comes in. How do you get the processes to really reduce, to make everyone work at the top of their license and so forth? So for radiologists, for instance, there's a huge radiology shortage across the country. The AI systems are constantly screening all of the images that are, happening throughout the day and triaging the ones that the AI system believes are the highest complexity or urgency, so that the radiologists who are there 24/7 reading can know exactly, okay, this patient's in the ER, 9 out of 10 CT scans are kind of not urgent. This one, this radiologist needs to call right away. Last thing
So it's bumping it up. It's bumping it up so that the physician pays.
But that's life or death.
Yeah.
And then the last thing I would say is we all now are wearing all kinds of gadgets and wearables and Aura rings and Whoops, et cetera. If you think about why patients see doctors, it's because they have a symptom or a pain or something. All of that's going to change over time. We're just at the beginning of it today where patients are self-diagnosing themselves. That self-diagnosis is going to become much more prevalent, so that most of the reasons why patients see doctors are going to be self-diagnostics. But you always are going to need to have that clinician oversight on top of it.
So Brent, that's a logical place to come to you with. So how do you balance, right, there's no shortage of ideas. So how do you balance innovation with economic reality in a really large health system environment? I mean, that's...
Absolutely. I'll start from a different end. We get a lot of great ideas or, ask for technology. And, I've made probably the bad joke that 80% of the time I'm trying to talk some of our partners out of technology. Because a lot of times it's a basic communication or an operational challenge or kind of strategic alignment. But when we find the place where, hey, technology can really support our clinicians or our frontline care managers, that's where the magic happens. And as we look at that, are we solving it for ourselves? How do we think about, and I think kind of building on your point, Hooman, how do we make it to where it will translate out into some of the rural hospitals as an example?
Yeah.
That is, I think, where we spend a lot of time, and we may have the most elegant tool, but it's teaching them like, hey, here's how you actually ingest the data. Here's how we work with our clinicians and do the training, or our APPs and do the training.
Yeah.
I think that's where the magic happens and where a lot of this stuff really scales.
Yeah. We're running a little short on time. Pradeep or Carl, how much interaction do you have with clinicians?
Well, I think a significant amount, especially, personally, but also between the two universities. I mentioned our PhD program. It's joined with Pitt, and a great many of the PhD students are working on problems that are in collaboration with clinicians at Pitt and also worldwide. And we also at CMU have the Center for Machine Learning and Health, primarily funded by UPMC Enterprises, and that is explicitly set up to encourage researchers and students to solve these kinds of problems by interacting with clinicians and other healthcare professionals at UPMC.
Okay. Pradeep?
Yeah, not enough is what I would
Not
say.
enough, yeah, never.
But I did have a grant from Center for Machine Learning and Health, and Pittsburgh, actually, it's a fantastic place with Carnegie Mellon bringing in the AI as well as Pitt, and we have this fantastic pool of healthcare research and practitioners. We need to do more, and it's actually worth thinking about what would be required. And I think the Center for Machine Learning and Health and other such venues that can bring researchers and practitioners together, I think would be a great place. And many of the questions that came about, which were, for instance, what are some of the roadblocks with healthcare practitioners using AI, I think can only be solved by all of these folks coming together. And the fascinating thing is that folks within AI, we talk a lot about artificial general intelligence and super intelligence, but you talk to healthcare practitioners, they say, I don't need a super intelligence, I need an intelligence I can work with.
Right, right. What's the practical application? Andrew, you gave us the basics. If you were prognosticating, where are we in 3 years, 5 years? Pick a number.
So again, going sort of to the basics, what these AI systems are really good at is recognizing patterns, complex patterns of correlation. And if we can sort of focus on that and say, what is it that we want to extract from all this data? What are these patterns? And then assess what these patterns are and how they can be used and what's meaningful. I think that's a good way to go. Rather than just throwing things at it and saying, what's the output? It's like, what is it that we find in our data and how can we use it? I think that's going to be a major improvement.
Yeah. Anybody else want to throw their hat in the ring with a prognostication? Dr. Friedlander, you want to?
I was talking a few months ago with an executive from one of the big companies and talking about AI and the role of AI in medicine. And what he told me was that AI is not going to replace doctors. Doctors that use AI are going to replace doctors that don't use AI.
Right. Right. I think that's a great place to wrap. A round of applause for our panelists, if you would. You know, this conversation really, I think, shows why Pittsburgh is so well positioned to lead world-class medicine, world-class computing, collaboration you've heard a lot about over the last couple of days. Thanks for participating. Have a great day. Take care.